We have with us Dr. Tauheed Zaman, who is the director of the Addiction Consultant Opioid Safety Program, and he's an associate clinical professor at the San Francisco VA and University of California, San Francisco. He is going to talk about cannabis use and related disorders. And Dr. Zaman, I'm glad we got the tech worked out, so we'll turn it over to you.
Great. Thank you so much, Chris and Alyssa. It is really a pleasure for me to be here. I will say when I'm in this presenter view, I can't see all of you, so feel free to unmute and ask a question as we go. I have a couple of questions for the audience embedded into my talk. It is meant for you to just take your best guess. I don't expect everyone here to know all the answers, but you certainly will by the end of the talk. I'm glad to be here.
Just so you know, I can see them. So if they're raising their hands or things like that, I'll intercede.
Great. I am fine with interruption. So let's dive into it. I wanted to start with this opening slide. I lived in the Haight-Ashbury for a long time. For those unfamiliar, it's an infamous part of San Francisco, really kind of tied to the hippie and kind of counterculture movements. And that has lasted. So you can see that this clock was set to 4:20. And while I lived there, it was an interesting place to live as an addiction psychiatrist because I was always surrounded by kind of cannabis, people selling marijuana, using marijuana, a lot of paraphernalia related to it. So, just to say that, cannabis has really been in our communities and among my patients and your clients potentially for a long time. I have no conflicts of interest to disclose, except to say that cannabis has historically also been quite controversial. As many of you probably know, it's a Schedule I substance federally, even though many states have moved towards legalizing it for certain medical and psychiatric indications. So my only disclosure is I will not probably resolve every controversy during this talk, but I'll certainly try to give you guys a helpful foundation. A quick bit of epidemiology. I won't get bogged down on it too much, but this is data from the National Survey on Drug Use and Health, NASDA 2018. This is a large national survey. If you've looked at some of the opioid data, you may be familiar with it. But the big takeaway here is that when we look at past year illicit drug use amongst people aged 12 or older, we see that marijuana is by far kind of the leading illicit substance there, far up above and beyond the other substance that I actually specialize in, which is opioids. So it even dwarfs opioids, even though of course the medical consequences are very different for the two substances. But just to know, this is quite a common substance in our communities. So that said, let's dive into some of my objectives for you all. I'm hoping that at the end of this session, you'll be able to describe some of the common preparations and their contents, describe the impact on some vulnerable groups, and by that I mean particularly adolescents and people with a history of mental health issues. List some of the medical indications for cannabis. It turns out what it's actually, or what some cannabis products are approved for by the FDA are very different from what's in our laws, in our state laws. List some of the formal mental health diagnoses related to cannabis addiction, which does exist, and then discuss maybe harm reduction and treatment options that folks might benefit from if they actually have a cannabis-related problem. The way I've structured the talk and a roadmap for getting to those objectives is I'm actually just going to tell you about a case. I'm an addiction psychiatrist, so I'm going to tell you about an adolescent case and talk you through it, including some of the very common questions around cannabis that came up in the context of that case. And I'm hoping that you all will chime in and we'll have a conversation about all of these subtopics, including a little bit of neurobiology, the preparations, psychiatric comorbidities, some of the medical indications, the risk of addiction, and finally treatment and harm reduction. Let me dive into it. So this is a case I'll call Kevin, not his real name. And I saw him a couple of years ago now, but saw him for a while. At the time I saw him, Kevin was 16 years old. He identified as a cisgender male of Latinx background, had long-term issues with anger, but most recently had also been struggling with more anxiety, had been binge drinking on the weekends, and over the last couple of months before he came to our clinic, had begun smoking marijuana more regularly with his friends. And what really got him into kind of care was his parents being concerned about poor school attendance and performance, which they thought might be related to some of the substance use. So they brought him into treatment, and he was going to groups, and his parents were going to groups. And Kevin was a really straightforward, kind of straight talking kind of person. And he told me early on that he vapes hash oil, and he consumes an edible brownie daily. So even though he's 16, he had a friend who was of age and in California could actually get access to those products and was kind of his supplier. And he said, I don't really see any problems with it. So I said, I actually do see some problems with it. I'm a little worried that this might be affecting you, and maybe it's raised some concerns at school. So what do you think? And are you worried? And he said, no, I'm not worried, because it's labeled. It's labeled, so I know exactly what I'm getting. I know how much THC and CBD are in my vape pen and in my edible. So it's labeled, and I'm not worried. So I know what I'm getting. So this raised the question for me about what's actually in there. And so I would like to pose that question to this group, and we'll circle back to the answer. So this first question is, the cannabis plant contains how many different active chemicals or cannabinoids? Is it 1 through 5, 10 to 50, 51 through 80, or over 100? And I would actually suggest go ahead and unmute and share the answer, or Chris can call on you as well.
So Kyle had his hand up first. So Kyle?
I believe it's somewhere in the order of 200 plus, if I'm not mistaken.
Okay, so your answer would be, the closest answer here, I think, is over 100, Kyle. Okay, great. Anyone else have a different answer?
I don't have that. I have the same answer. I would say definitely more than 100.
Okay, great. Anyone else?
Andrea?
I think I've heard 400.
400. Okay. Helpful to know. I will say this is a savvy group. Most people guess much lower when I give this talk. So let's circle back to this, and I think you'll feel confident you know the answer. This is a picture. Oops. So I might ask, maybe if you have some noise in the background, maybe go ahead and mute yourself if you don't mind. This is a picture of trichomes. Trichome comes from the Greek word for hair, and it refers to these small translucent outpouchings on the surface of the cannabis plant. This is kind of a near microscopic view. I share this with you because this is where all those cannabinoids come from. So this is attached, or these trichomes are attached to glands in the plant that secrete all of those chemical products. Every cannabis product you all will encounter, and that our population encounters, has found some way of taking the chemicals out of these trichomes and putting them into some consumable form. So good to have a visual of kind of where these chemicals are coming from. And what's in there? So generally we think that there are two kind of major strains of cannabis, so sativa and indica, that there are different mixes of CBD and THC in there, though now there are many, many hybrids as well that have been developed over time. But in terms of what's actually in there, the chemical composition, it turns out there is an entire alphabet soup of different cannabinoids that are in there. In fact, at last count, over 100 that have been actually studied to some degree. Probably many more there, but which have not been studied well. The two that have been studied the most rigorously are the ones with which you may be familiar, which is tetrahydrocannabinol, THC, there in the bottom left, and then cannabidiol there in the bottom right. But what I always like for people to know is that, yes, we are studying those. There's much more research to be done, but gosh, are there many other cannabinoids in there that can have a physiologic effect? Absolutely, and I think we're very early in kind of understanding that. I mentioned that I talk about vulnerable populations, and one of those populations is adolescents. And I want to mention this in particular because this applies to every substance that you all might encounter. The brain actually develops from the back to the front, and brain development doesn't actually complete till much later than most people think. Any quick guesses as to what age the brain finishes myelinating or kind of developing fully? Feel free to shout it out. I'll take one or two guesses.
Closer to 30.
28.
28.
Close to
Okay,
30.
Heather. Close to 30. Okay. Yes, good guesses. Very close. And also, I think we all know adults who beyond 30 still, you might question whether or not they've fully finished their adolescence. But so the brain actually, brain development as measured by myelination, you can see myelination is in blue in that image, kind of going from the back to the front. The brain gets more blue. It actually completes at the age of 26. However, the order in which it develops is also important. In early adolescence or kind of early teenagehood, the cerebellum develops. That's the back part of the brain. That's motor coordination. So that's why we see these, gymnasts, athletes, incredibly young, amazing motor coordination that they can do all of these kind of physical maneuvers, which would probably, put me in the hospital. And then later in life, you get kind of the social emotional development. This is, peer groups. This is first crushes. This is, leave me alone, mom and dad. I just want to hang out with my friends. This is the emo teenager. Many of you may know, / maybe were. The limbic part of the brain developed. And finally, this is the crucial point. The last part of the brain to myelinate are the frontal lobes. These are the parts associated with thinking, executive function, cognition, impulse control, all of those things we associate with being kind of a healthy adult and responsible citizen. So keep in mind, these are the last pieces to develop. So we want to protect the brain as long as we possibly can from the influence of substances, including cannabis, alcohol, opioids, because we want these frontal lobes to have a chance to myelinate and develop properly. So important to protect young brains from substances, including some of the chemicals in cannabis. So neurobiology is great, but what do we actually know about outcomes? What are the outcomes around adolescents who use heavy amounts of cannabis? And I'm defining heavy here as daily cannabis use. Well, there are age and dose dependent impacts on a number of outcomes. So the earlier the age and the higher the dose, the more risk of lower rates of high school completion, going to university, actually developing physiologic dependence to cannabis, other illicit drug use, suicide attempts, depression, and welfare dependence. Now, I want to pause here and say that how do I talk about this, or how does this impact my clinical care? I am not a fan of fear tactics. I do not sit there and kind of share all of these possible outcomes with people who come in, but I target it to the actual values of the person. So if someone really does want to finish high school and move out of home and go to university, et cetera, I want them to know a little bit about the risks that heavy cannabis use might pose for their particular goals. In general, going through and kind of listing all of these impacts for someone has very little impact and tends to kind of put them off and come off as quite judgmental and shut down the conversation. So I try to avoid that if I can. I think I see a hand from Kyle. Do you want to unmute and maybe share a question?
Yeah, as I've covered legalization debates over the years, you mentioned physiological dependence. I've heard a lot about psychological dependence, but not so much physiological. Is that for adolescents, or does that apply more broadly as well?
Great question. So it turns out dependence is a physiologic phenomenon. However, because there is that increasing importance that we've seen similarly medically of the psychological portion, we have actually moved away from using the terms abuse and dependence for substances and moved to the use disorder terminology. And Kyle, hold me to it. I'm actually going to circle back to that in regards to cannabis. So if I don't answer your question even more clearly by the end of the talk, please let me know. Okay.
I have a question about this as well.
Please go ahead.
And this is, I'm sure there are like dozens or hundreds of studies, but the studies that find a link between marijuana use and all of these like terrible outcomes, do they distinguish between correlation, causation?
Yes.
Yeah.
Great question. So I think, Christine, what you're alluding to is one of the trickiest but most important concepts in science, which is that association is not causation, right? So these are studies of association. And I will say, when there are studies of association, it's really important to control for other factors, right? So are these people also drinking really heavily or using lots of opioids, et cetera? What I can tell you is that these are studies of association which controlled for those other factors. And in addition to that, there have been actual neurologic studies like fMRIs showing the changes in the brain as people use most cannabis. So that points towards more of a causation, but these studies I'm referring to, including this Lancet review, are studies of association, but great point. Speaking of associations, I just want to tell you that there have been studies of kind of perceived risk versus regular marijuana use in adolescents, including 12th graders. So this is a graph over time of percentage of US 12th grade students who report daily use. So not using on the weekends with friends or once in a while, but daily use, right? Perhaps similar to my patient Kevin. And you can see that as you look at the percentage of people who perceive use to be risky versus the amount to use, that the two graphs are mirror images of each other. So when perception of risk goes down, daily use goes up, and vice versa. This is probably quite intuitive. However, it's important to know that this data exists because legalization, advertising, all of those things that we're seeing come into play absolutely affect adolescent perception of risk and therefore might lead to more increased use, including daily use. We should just be aware that that's a phenomenon that's been studied. So we're going to circle back to the question, the cannabis plant contains how many different active chemicals or cannabinoids? You all are absolutely right, over 100. So it's a great job. The questions do get harder, I'll warn you now. Preparations, so just so you all know, a quick overview of preparations, some of which you may be familiar with, but certainly there's the dried plant product itself from the marijuana plant. There's hashish, which is basically a concentrated resin cake. And that is produced by dry sifting. So you saw the trichomes on the surface of the plant, finding a way to dry sift those plant products and draw out the chemicals and put them in a more concentrated solid form. That's how you get hashish. There can be tinctures used sublingually. There can be hash oil, which is the most concentrated form of cannabinoids, and it's actually produced by solvent extraction. So usually butane hash oil or another highly flammable solvent basically dissolves all of the chemicals off of those trichomes, and then evaporating that liquid leaves this kind of sticky residue, and using that or kind of inhaling that is called dab. Now, what is the problem with people trying to actually make their own hash oil? Well, when you're trying to evaporate really volatile liquids, you get fires and you get explosions. And so my emergency room colleagues have seen the results of some of those. And finally, there could be plant infusions, which are basically material mixed with cooking oil, butter, all kinds of different products. So those are just some of the common preparations. This is a picture of a dispensary in San Francisco. I did not take this picture. I have not been there, but to be honest with you, it kind of looks like a place many people would like to go. It's pretty chic. They have nicer rugs than I do, and my clients go to dispensaries and they tell me about how nice some of them are, though they vary. And what it reminds me of is that there are other reinforcers to going to dispensaries. There's this increasing kind of social club-like feel of it. Many of the dispensaries offer Reiki or a massage in addition to kind of the cannabis products. So it's really turning into this full service industry with the substance built into it. And I just want people to keep that in mind, that it's happening. In terms of the preparations or products you might see, I think gummy bears and worms are very, very common. I talk to clients about the safety risks because this looks like candy and in many ways is candy, but it's candy for adults. So there have been cases of children getting into these and having cannabis overdoses and ending up in the emergency room. So I always talk to people about the importance of safe storage. There are the vape pipes with which you're familiar, and there's the dried plant product that you can get. And there's everything else. So from potato chips to to cookies to drinks, there are a whole host of different cannabis-based products. And important to just know that this is marketing. This is meant to appeal to a broad range of consumers. So this is really consumer marketing. Synthetic cannabinoids are out there. This is a whole other talk. So I'm going to mention this briefly to you today. Synthetics go by many names. Spice, K2, Joker, Mamba are just some of the common ones that I've heard. They often come in these kind of these bright packages, but basically it consists of a synthetic compound sprayed onto the plant product, which when ingested actually binds to the same receptors in the brain that regular cannabinoids do, but have much, much more powerful and potent effect. So this can actually be deadly. It's important to know that synthetic cannabinoids can lead to cardiac issues, renal issues, psychiatric issues, including psychosis, seizures, and death. I have seen this happen, and also probably helpful for you all to know, synthetics don't show up on standard urine drug screens. So we actually have to ask about it, and if someone admits to it, send it out for specialty testing for synthetics, because most standard drug screens will not pick up synthetic cannabinoids. And then there are some preparations that look a little different. These are pictures I took in my own office of patients who brought in their kind of medical marijuana or cannabinoid product containers. There's no confidential or HIPAA protected information on these containers, but how would you describe these versus kind of the rainbow of different products that I shared earlier? How would you all describe this packaging?
I'd say medically approved. And that's what it looks like. It says medical, it's in a prescription jar.
Yes, absolutely. Looks like real medicine, exactly. So I completely agree. This is marketing of a different sort. This is meant to appeal to a person who really sees themselves as having a condition for which they need a marijuana prescription. Right now, it turns out a lot of that is not evidence-based, but gosh, that hasn't stopped the marketing. So this looks very much like, like the antihistamine, the allergy medication I take every day, except that it's, I guess in this case, it's called Blue Mazar. But yes, very medically packaged. And you'll notice, this may be a little hard to see, but on the bottom left, the package is labeled with THC and CBD percentage. So I saw this and I said, well, was Kevin right all along that he knows exactly how much THC and CBD is going into his system far better than I do, because the packages are actually individually labeled. And it turns out this has actually been studied. So cannabinoid dose and label accuracy in edible medical cannabis products has been studied. This was from a JAMA study in 2015. Basically, if you all were to take a guess as to what percentage of cannabis products were labeled accurately based on THC content, this is a group that took every edible product they could find from dispensaries in Seattle, San Francisco, and Los Angeles, and they put it through a chromatographer, so they saw what's actually in there and compared it to the label. If you were to guess what percentage are labeled accurately in terms of THC content, what would you guess? And defining accuracy as within 5%. So
I'm seeing answers coming in 30%, 10%, 10%.
Okay. 10% is on the low side of guesses, usually 2%. Okay, Alexis, you are even more of a pessimist than I am. 2% is the lowest guess. So it's actually 17% were labeled accurately in terms of THC content, with roughly equal amounts over-labeling and under-labeling of content. And so, when Kevin says, I actually know exactly what I'm getting, if I were being facetious or if I were being flippant, I'd kind of say, actually, there's about a 17% chance that we know what you're getting, right? I didn't do that. I wouldn't do that. But I will say this is improving. So with increased infrastructure, with increased access to testing and standardizing some of these products, this is getting better. But a lot of products are still not labeled accurately in terms of THC content, likely CBD content, and then of course many other cannabinoids are not accounted for. So we just want to make sure we keep an eye on this and kind of hope for better accuracy over time. So he kind of said, okay, well, I guess I might not be getting everything that, exactly what you think I'm getting in there, and maybe the labels aren't accurate, but actually like everyone's doing it. So a lot of people with mental issues smoke pot. He said, I have issues with anger, I have issues with anxiety. That's why I'm seeing you, you're a psychiatrist. So a lot of people with these issues smoke pot, right? And so this got me to the question of, okay, he's using it for what he thinks is as like an anxiety disorder, right? But what has the FDA actually approved cannabinoids for use in? And this is my next question to this group. Is it anxiety? Is it glaucoma? Is it seizures? Is it complications of chemo and AIDS? And or is it pain and multiple sclerosis? Any guesses from the group? Seizures, someone guess seizures, 3 and 5 seizures and multiple sclerosis, glaucoma. Any other guesses? Glaucoma, okay. Chemo, seizures, glaucoma, pain, and multiple sclerosis. So you think this is more of an all of the above type question, all right?
I'm just gonna say everything.
Everything, okay, it's just been approved for everything. Okay, good to know. Let's circle back to it. We're gonna know the answer by the end of this section. So let's look at co-occurring mental illness. And I won't spend a ton of time just talking about this, but just to know, this is based on NESARC data from 2015, but the rates of co-occurring mental health issues have been studied in those with a history of marijuana dependence. This is again using that old terminology of dependence and abuse versus the general population. I want to bring up here Christine's point. I think it was you who said that association is not causation. So we actually don't know which way, if there is a causation, it goes. But helpful to know that when we look at a host of different mood and anxiety disorders, the rates among people who are also dependent or were dependent at that time using marijuana are across the board much higher than in the general population, right? So there is this association with other co-occurring mental illnesses, even though we don't know if there's a causative effect in either direction. However, psychosis is a different picture. In psychosis, this has been really well studied. Cannabis absolutely has a causative effect when it comes to psychotic disorders and worsening outcomes in people who have those disorders. So this is from a review in Lancet in 2014. I've shared a whole set of references with you at the end of this talk, but there is an association with increased risk of psychotic outcome. What does psychotic outcome mean? That's kind of an odd term, but outcome is defined as brief episode of psychosis, emergency room visit, hospitalization for a psychotic break. There is a dose-dependent risk. So the more cannabis someone uses, the more at risk they are of a psychotic outcome. For people who have a family history of schizophrenia or another psychotic illness, it speeds up the onset of psychosis by an average of about 7 years. There are higher rates of paranoia, hospitalization, and on brain studies are imaging lower brain volume. Now, I want to pause for just a moment here and say, you heard me say I don't like scare tactics. However, in patients who have a history of psychosis, either personally or who have it in their families, I absolutely feel I have an obligation to share this information with them and just let them know, look, like, I just want you to know there's this association. What do you think? If you're not willing to cut down or stop yet, that's okay. How do we watch out for these risks? How do we take a harm reduction approach to protect you from psychotic outcomes? So I think this can be quite important. Will, I think I see your hand up. Did you want to ask a question?
Yeah, just quickly, when you said more use, are you talking about over years? Are you talking about just if you have a higher dose, it leads to one episode, or like, I mean, yeah.
Yes. This is such a good question, Will. And I'll tell you, it gets to something my patients often ask me, which is in response to this conversation, they'll often say, well, just give me a number. Like, how much is okay? Are we saying like weekends are okay? Are we saying like every other day? And I hem and haw and say, we don't have that data yet. And then ultimately what I end up saying is, look, for the average person who has no history, like no family history, no personal history of psychosis, I would say try to avoid daily use. However, for people who have a personal history of psychosis or a family history, just several days of heavy dose use can be enough to develop psychosis. That psychosis does clear up after the cannabis is out of the system, so it can pass in a few days. But if someone has an underlying schizophrenia that is being unmasked, that can become permanent, right? So that's the best answer that I can offer, Will. Does that kind of get you part of the answer you were looking for?
Yeah, because I saw that by onset by 7 years. I hadn't seen that before. I've done some reporting on this, so I hadn't seen that number before, and I'm trying to understand what that meant exactly. So
Yes, and actually I apologize. I thought I'd put it at the bottom of the slide, but it's certainly in the references. The study is by Moore, M-O-O-R-E et al. And it's in the Lancet, which is a great journal. Nassim, did you have a question?
I do. Can you describe what psychosis is exactly, or what you're referring to when you talk about psychosis, or family history of psychosis?
Yes, absolutely. Great question, because we use the term psychosis colloquially, very different from what it means medically or psychiatrically, as some of you may know, and I think Nassim, you're alluding to. When we say psychosis in a psychiatric context, what we're talking about are changes in perception. So auditory hallucinations, visual hallucinations, perception in terms of paranoia as well, increased risk of paranoia, and for some people, disorganized thinking. So people can have very disorganized thinking, trouble completing tasks. So it's a combination generally of those symptoms. Now, psychosis long-term can also have a set of negative symptoms, which is more withdrawal, more kind of numbing, more amotivation. That is less what tends to happen acutely with marijuana-induced psychosis. What you tend to see is much more of the positive symptoms, which is the hallucinations, the paranoia, the disorganization, etc. Does that answer your question, Nassim?
Yes, thank you.
Okay. Perfect, no problem. I'm going to go on here. So medical marijuana, are there any psychiatric indications? You know, Kevin said he's taking it for his anxiety. So I was actually with the American Psychiatric Association in 2013, and I did 6 months of research and helped them write this kind of position paper on psychiatric indication. All of that work could have been basically boiled down to one line, which is there are no current psychiatric indications for which any cannabis product has been proven to be helpful. However, we were careful to note that that's not because of a lot of negative studies showing that cannabis does absolutely nothing for many psychiatric disorders. It's actually because of a lack of studies, right? So we were careful to mention that more study was warranted. This was reviewed again in 2018. And the American Psychiatric Association still opposes the use of cannabis as a medicine for any psychiatric indication, because there are so many associations with poorer mental health outcomes or worsening depression or anxiety in association studies, and not enough studies really showing that there's a long-term benefit. However, there are some non-psychiatric indications for which the FDA has approved cannabis-based products. This is getting back to our multiple choice question. So several of you were right. Nausea and vomiting related to chemo, anorexia and wasting related to HIV, and rare childhood forms of epilepsy, not every type of epilepsy. These are the FDA approved cannabinoids that are on the market. Dronabinol has been probably around the longest. It's a synthetic, approved for anorexia and wasting in AIDS patients. Nabilone is another synthetic approved for nausea and vomiting in chemo patients. And just in the last couple of years, the newest agent, cannabidiol or Epidemiology, is actually plant-derived CBD, and it is approved for Lennox-Gastaut and Dravet, which are two rare forms of childhood epilepsy. So these are the FDA-approved cannabinoid uses. Wanted to share this reference with you. I won't go through this table or this chart in detail, but the proceedings of the National Annals of Science did a really thorough review of all of the health effects of chronic cannabis use by organ system. So if you all are interested, I think this is a great reference, and it really breaks it down by respiratory risks of injury, cancer, cardiac immunity, and pregnancy risks. I put some of those in here. I'm not going to go through each organ system in detail, but these slides and that reference will be available to you for the future. So cannabis question 2, the FDA has approved for cannabinoids for use in which of the following? So many of you got it right. It's actually seizures and complications of chemo and AIDS. However, not pain and multiple sclerosis, not glaucoma, and not anxiety, at least not yet. And then he said, well, okay, but I don't know why you're worried, because you can't really get hooked on that stuff. You know, you have people in your waiting room who are like withdrawing from opioids, you know, and they're like clutching their stomachs, and there are people who are trying to come down off of that. So I don't really understand why I am here, or why you're worried about a little bit of marijuana, because you can't really get addicted to it, right? This is a common belief that I hear from adolescents, from adults, sometimes even from other physicians. So let's start with a question. which of the following can increase the risk of developing a cannabis use disorder, or actually, what we think of as an addiction, right? Is it parental attitudes towards use? Is it early onset or adolescent use? Is it the route of administration? Are people, smoking it, eating it, using a topical, whatever? Or is it regular and regular/daily use? Any guesses from the group? Okay, I see 2 and 4. I see all of the above. Okay, all of the above. 1, 2, and 4, including parental attitudes. Okay. Andrea, all of the above as well. Okay, sounds good. Let's find out. So it's important to know that there are DSM-5 criteria for 3 things related to cannabis use, for 3 diagnoses related to cannabis use. Many of you may be familiar with the DSM. That's the Diagnostic and Statistical Manual of Psychiatry. That's what we use to actually diagnose people with conditions. All of our kind of, bona fide psychiatric diagnoses, whether it's, depression, anxiety, schizophrenia, and substance use disorders, are all basically contained in this manual. And we have evidence-based criteria to actually diagnose people with cannabis intoxication, cannabis withdrawal, which absolutely happens. I've had many patients go through marijuana withdrawal, particularly when they get admitted to the hospital and suddenly don't have access to their usual cannabis product, and cannabis use disorder, which is an addiction. Now, I'm not going to go through cannabis intoxication just because I think everyone here probably knows what that looks like. So I'm not going to go through that in any detail. Cannabis withdrawal, however, can happen. And so we define that as within having 3 of these symptoms within 1 week of stopping cannabis use. That includes irritability, anger, aggression, anxiety, sleep issues, and appetite issues, restlessness, depressed mood, and at least 1 physical symptom. So abdominal pain, shakiness or tremors, sweating, fevers, chills, or headaches. I have supported a number of patients through cannabis withdrawal, and it can be really intense. And I think we really underappreciate it when people get, end up in the hospital and don't have access to their cannabis, when they end up in jail and don't have access to their cannabis. It can really be incredibly uncomfortable. Not as uncomfortable as opioid withdrawal, but it can be pretty bad. So what about actual addiction? Like, what do we know about the numbers of people who end up getting actually an addiction diagnosis at some point in their lives? These are the best data that I can find. Among all users of cannabis, actually the minority end up developing an addiction at any point in their lives. It's about 9%. However, when you look at people who start as adolescents, again, early on, before that brain development has finished, the rate goes up. It goes up to 17% at some point in their lives. And amongst daily users, 25 to 50% develop a use disorder at some point in their lives, depending on the study that you look at, right? So what is my takeaway here? My takeaway is here, look, a lot of people use cannabis without developing any addiction at any point in their life. However, using early and using regularly can increase that risk long term. What can we do for these folks? Right. Oh, sorry, Christine, I saw you unmute.
Oh,
did you want to ask a question? Go ahead. Yeah.
You described the criteria for what withdrawal is. What the definition for addiction? I mean, is it like they need it every day, or they experience withdrawal if they don't have it? How, or does it
good question.
Actually interfering with their daily functioning? Because everyone's addicted to coffee, but we don't seem to have an issue with that because people helps them function. So I know people who use marijuana and they're like, I'm not but it's like coffee.
Yes, and I've actually got a cup of coffee right here. So good question. I didn't go through in detail the criteria for an addiction, because I think I thought you may get it in other sessions already and didn't want to repeat it, but let me briefly recap what addiction actually means, right? When we step back, before we get into the medical definition, addiction is ongoing use despite consequences, right? So you can imagine that can apply to a whole host of things, right? So that in itself is not enough, really. That might kind of raise our concern and say, let's screen if someone has an actual addiction to, tobacco, to maybe even caffeine. Let's ask more. But how do we know it's an addiction? First, 2 questions. Is there significant functional impairment related to the substance? And or is there significant distress related to the substance? You look at those 2 things. If either of those are yes, then in the DSM has 11 different criteria for an addiction. And I don't have a slide with all of them listed, but it absolutely includes hazardous use, social impairments, physical dependence, going through withdrawal. And depending on the number of those 11 criteria that you meet, you get diagnosed with a mild, moderate, or severe use disorder. Now, I think it's just important to know that because we use those same 11 criteria for every substance: alcohol, opioids, tobacco, cannabis, meth, everything. So to answer your question, Christine, the term addiction is very kind of well defined, and I think meant to be very kind of exclusionary of people who just kind of use casually and don't have significant impairment yet. Does that answer your question?
Yes, thank you.
Of course. So jumping back into treatment for people who do have those conditions, you know, there are 0 FDA approved medications for cannabis use disorder or even to help people through cannabis. So this is off-label use of medications, which I always like to tell people. You know, you all may or may not want to know all of the names. Drug names can be boring, but important to know that there are small randomized controlled trials that show effectiveness of a couple of common medications. Gabapentin is a very common medication we prescribe for many different indications, including chronic pain and anxiety and alcohol withdrawal. It turns out that can be helpful for cannabis as well. And acetylcysteine is actually a nutraceutical. So it's actually available over the counter at like CVS or your local pharmacy. We can also prescribe it. Those two are the most commonly used to help people with cannabis withdrawal and cannabis use disorder. The other two I put in red are actually synthetic cannabinoids. I don't prescribe them. I leave that to my colleagues in HEMONC who do it for cancer-related diagnosis, for for complications of HIV. You might remember those other indications. So I don't touch those medications, but they have been shown to be helpful, which makes sense because they're basically synthetic cannabinoids. Treatment is largely behavioral, so there's no one good best modality of behavioral treatment. However, as with other mental health conditions, there's really good evidence for cognitive behavioral therapy or CBT, either individually or in groups, for motivational interviewing, increasingly for contingency management. So I don't know if folks are familiar with contingency management. I know this is a very savvy group, but contingency management is actually the gold standard treatment for another addiction, for stimulant use disorder, so cocaine or methamphetamines usually. It basically involves giving people a reward for having negative urine drug screens, or the chance of a reward. They kind of come in and they get to draw a strip of paper out of like a goldfish bowl, and there's a chance that it has a reward, like a monetary reward in it. And it turns out that is incredibly effective in motivating people to stay abstinent over time. And it also turns out it's cost effective, just in terms of preventing hospitalizations, preventing other adverse outcomes related to use. So there's some emerging evidence for that with cannabis as well, but generally group therapies are the mainstay. So cannabis questions: which of the following can increase the risk of developing a cannabis use disorder? I will tell you, I think all of these could. Not all of these, however, have been well studied yet, but the ones that have are early onset or adolescent use and regular daily use, which won't surprise you given the themes in my talk. So great job, those of you who guessed 2 and 4, but everyone else, you're probably not wrong. It just has not been adequately studied. So what happened with this case? You know, Kevin and I worked together for a long time, and he ultimately said, I don't want to stop. I think it's good for my anxiety, but we can keep an eye on it over time. And for me, this was a perfectly acceptable outcome, because by far the most important thing to me is being able to have open and honest conversations with my patients about their use, to be able to guide any kind of changes in use around adverse effects they might be having. And I'll just share with this group, he cut down on his use because the biggest piece of info for him was that the labeling was not accurate. And he was like, I want to know what's going in my body. So if you're telling me there's other stuff, I don't like that. So he actually cut down on his use enough that he was able to actually finish high school. And I didn't continue with him beyond that because he was functioning so well. He didn't need to come to our clinic anymore. So he continued to use long term, but cut down and took this harm reduction approach, which was actually really, really effective. Speaking of harm reduction, there are harm reduction guides out there. This is one that I like from the American Journal of Public Health Policy. And even 10 years ago, the gold standard for every substance use in terms of treatment was abstinence. I think that has changed. I think we have moved towards, for the appropriate people, moving to harm reduction. And so I frequently talk to my patients about, yeah, okay, abstinence is the best way to avoid risks, but here are some other things we can do that are not abstinence-based. So, you know, delaying use, avoiding early age of initiation, avoiding high frequency use. Even though labels are inaccurate, doing our best to choose low potency THC products, absolutely abstaining from synthetics. I will say I'm pretty black and white about that, just given the health risks. Avoid combustible products. I mentioned this for patients who have respiratory conditions. If you all know people who have, you know, chronic COPD, asthma, bronchitis, like maybe avoid the inhaled forms of cannabis. Avoid deep and risky inhalation. Driving is a huge one. Cannabis impaired driving is a big problem. It affects our reflexes associated with driving. You've heard me talk about avoiding use in high-risk populations, including people with psychosis and other addictions, and tracking use over time. So actually, my patients have taught me this. You can actually get metered vape pens where you can track the amount that you're using each day, and people have used that as a way to track their amounts of use and cut down over time. So I think a non-judgmental harm reduction approach can be really effective. Before I kind of go to my final slides, I'll share some take-home points with you and take some questions, additional questions. Remember, cannabis is undoubtedly risky for the adolescent brain, just based on those association studies. There's a high rate of comorbidity with other mental health illnesses, so we always want to screen for that and be aware of it. The cannabis products on the market contain THC, CBD, but over 100 known compounds. Not all have been well studied. We have clear criteria for intoxication, withdrawal, and use disorder. The treatment is largely behavioral, right? Those group and individual treatments we talked about, but also some off-label meds that I mentioned. Early and daily use is associated with poorer outcomes. There are some medical FDA-approved indications, but no FDA-approved psychiatric indications currently. Individual risk stratification is crucial. So do you have a history, personal history of other addictions, of psychosis, et cetera? And harm reduction measures are crucial for the people who aren't interested in or able to abstain right now. And finally, you know, legalization has happened across the country, and there are great arguments for legalization and some reason for concern, because legalization, you know, brings up questions for me as a physician about how do we protect vulnerable populations, including adolescents. I also do a lot of work with veterans, so how do we protect, you know, veterans who might have poor outcomes? And how do we do research with what is still, you know, federally a Schedule I substance, which can make it harder to study, right? So that's a significant barrier to research. So how do we navigate that? And so with that, I want to share some additional resources. These are all public facing, and I share these sometimes with my patients. And then thank you, and happy to take any parting questions. I see a number of hands. Chris, is it okay if I just kind of call on people in order?
Yeah, well, let me, well, first of all, how much longer, how late can you stay?
I can stay 10 more minutes. You might have heard my pager go off in the background, but 10 minutes is a reasonable window to return a page.
Okay.
Go ahead.
Well, if, so we have 10 minutes of questions. So I see 6 hands go up. If you can each give a quick, tight question and Dr. Zaman give a tight answer, we can maybe get these 6 in. Barbara, Kyle, Madeline, Alexis, Kathy, and Will. And if there's any other leftover questions, you know, I'll try to connect you with Dr. Zaman later on, but let's go to Barbara first.
Okay, what you say is, I think, very troubling, because a lot of states are legalizing marijuana, yet you bring great arguments. You know, in California, I know because my son lived there, you could get it for any kind of medical reason. You have back pain, you know, whatever. What do you think, as more and more states are either legalizing marijuana or considering legalizing marijuana, what are going to be the ramifications?
Great question. So what we know is that, you know, without getting into whether or not, you know, marijuana should be legalized, I'm not a legal expert and I can't comment on whether or not it should happen or not. However, can I talk about potential medical ramifications that we should be cautious of? I can. What we know is that whenever there is increased access to any potentially addictive substance, more people are going to use it. And as a result, more people are going to develop some use disorders. When we look at, the number of bars that are in neighborhoods, the neighborhoods with more bars have more people with alcohol use disorder, right? So I think we need to be cautious about more people potentially having not just addiction, but some of those other outcomes, poorer outcomes that I talked about, right? So in terms of finishing school, in terms of job attainment, I think those are things we need to watch out for, and we need to watch out for that in the vulnerable populations. So, historically, the tobacco industry targeted vulnerable populations, targeted people of color, targeted adolescents, targeted veterans. So we need to watch out for whether or not those people are adequately protected as this substance becomes more common in our communities.
All right, Kyle?
You referenced it at the very end with FDA scheduling, as well as earlier and throughout all of the unknowns, especially when it comes to more of the specifics. How critical would it be for you to see the FDA reschedule marijuana in order to answer some of the questions, some of the beliefs that some of your patients have? And is that the number one thing that the federal government could be doing right now in order to address disorders from marijuana?
I think it's one of the important steps that could be taken. So just to say, a number of other physicians and I actually have advocated through our organizations with the DEA to actually reschedule or unschedule cannabis just for research purposes, or to put it in just a different category that makes research more possible. The DEA has said no for a number of complex reasons, but I think it's an important step. However, the DEA has, and the federal government has, lowered some barriers to doing research, and that has looked like making, the approved growers or the approved providers for research formulations of marijuana more accessible to people, giving out more permits to do research, but the barriers are still high as long as it's a Schedule I substance. So potentially rescheduling it or unscheduling it could improve access in terms of research, but I think it's a complex question.
All right, Madeline next.
Yeah, you mentioned coming down off of opioids is going to be much more intense. When you said it impairs people's driving, I know there's been studies that show that marijuana doesn't impair you in driving as much as, or it's not as dangerous as drunk driving and those sorts of things. But do you think it's helpful to compare other drugs to marijuana when discussing kind of outcomes, or do you feel like it should be presented in its own light?
Great question. The answer is both. So by that, I mean that I think if someone is using multiple substances at once, the combined effect on multiple outcomes, including driving related incidents, is actually huge. So when people drive drunk and high, which they do all the time, there is actually a synergistic effect on the reflexes associated with driving. So people sometimes say like, well, doesn't marijuana just slow you down? I might not, I think probably what I'll do is just drive much slower and stop at the red light like 50 feet before I need to. That's actually not what happens. So because of the synergistic effect between alcohol and cannabis in particular, the rates of MVAs are much, much higher. That said, if someone is using just one substance to excess to the point that it's affecting their functioning, I'm absolutely going to talk about that as well, right? So can one substance in excess lead to significant risk of injuries? It can, and that's been well studied with marijuana. So I talk about the risks. And I think I push back a little bit against that common notion that everyone who's high on pot is just a good driver because that's all they can be because they're slower. The story is much more complicated.
All right, Alexis.
We know if and how cannabis addiction changes the brain and the brain structures and brain function, and how that compares to addiction to other substances?
That's a really great question because there is overlap with the way it affects the way other substances affect the brain, in that it's the same reward circuitry. So there's basically a reward circuit in the brain connecting a few different key structures within the brain that basically gets set off. It's largely a dopamine and opioid based pathway that gets set off by opioids, by alcohol, by meth, by cannabis. Like there's that same structure, right? However, the actual receptors that cannabinoids attach to in the brain are very different from opioid receptors or receptors for alcohol. So there's a way in which the initial portion of it, how it actually attaches and affects nerves and the nervous system. And there are steps in between to how it sets off that reward pathway that are actually different from some of the other substances. Each substance has its own kind of unique way of getting there. So all of that is to say, to summarize, it sets off the same reward pathway, but the actual receptors it attaches to in the system initially can be different. So that is an ongoing area of research.
Right, Kathy.
Thank you. I was just curious to know if you have any thoughts on the use of marijuana on individuals with dementia. I had done a story on that recently, and there was a doctor here that was sort of studying it because a lot of family members struggle with typical medication that's used to prescribe to sort of help with behavioral issues, and have been going to dispensaries and sort of fiddling with different tinctures to give their loved one, you know, CBD or THC to sort of help minimize any kind of outbursts or any sort of behavioral issues. So I wanted to see what your thoughts were, and if you know if this is being studied more.
Yeah, it's such a good question. So I will say, so first of all, there aren't any good studies showing the efficacy in people with any type of dementia, as far as I'm aware. Dementia is actually a large category of illnesses. There are many different types of dementia, right? So, you know, there's Alzheimer's, there's vascular, there are different types of dementia. So even within that umbrella, there's a lot of diversity, right? So my thought is probably each individual type of dementia would need to be adequately studied separately. And as far as I know, that has not happened. So I'm not a dementia specialist. So I want to just acknowledge my limitation there. My concern would be that we know that cannabis can have some short and long-term cognitive effects, right? So with each person, I would really want to weigh the risks and benefits of kind of that behavioral control versus making their cognition sometimes worse, because of course dementia is often an illness that affects memory and that affects cognition, right? So could it be that that's actually a risky population that we want to protect from more cannabis exposure? I think that would be my concern, but I'm not aware of any good studies that have looked at it for specific dementia diagnoses, but that might be my own lack of expertise in that area.
Yeah, thank you.
Yeah.
All right, Will Stone.
So since we're dealing with association with a lot of these studies, and we already have quite a few years of lots of states with legal marijuana, what do we know about the psychiatric impacts on the population in, you know, for the last 8 or 9 years in a variety of states that have legalized marijuana?
Yeah, great question. So, you know, what we know is that rates, the things that you would expect to go up, did go up. So rates of cannabis use, rates of cannabis use disorder, rates of adverse outcomes related to cannabis use all went up. Now, is that balanced out by some of the kind of legal and social benefits of not having this be a substance that people are actually penalized for and thrown in jail for, particularly certain populations, you know, people of color, you know, like, is there a net benefit to society? You know, potentially. But I will say, in terms of the diagnoses that I commonly treat, like the use disorders, the adverse outcomes related to cannabis, all of that has gone up. Now, I will say, you've heard me say I do a lot of work with opioids, and initially there were some kind of some promising data that, oh my gosh, rates of overdose are actually dropping in the states that legalized marijuana. And I, along with others, were so excited because talk about like the most concrete outcome, like death by overdose, right? So every physician wants to avoid that no matter what, right, as much as possible. However, I have to tell you, that has actually reversed. So all of those states that had that initial dip in opioid overdose deaths have actually reversed and now have rising rates of overdose. So there was an initial effect where perhaps people were using less opioids because they were using cannabis, but now that has reversed. So what I'll say is, I think it's really complex depending on the psychiatric condition or the outcome that you're talking about. The ones with which we would intuitively affect would go up whenever you increase access to a substance has gone up, and the benefit in terms of opioids hasn't really been there yet. So that's my partial answer there. I think I can take one more question. My apologies, but I have to run.
Understood. You have patience, and so Georgia is the last question.
I was just wondering, first of all, thank you for your time, but I was just wondering, what are you seeing in terms of fentanyl mixed with marijuana? And is that playing into the increase in overdoses?
Oh, great question. So fentanyl is increasingly common as an adulterant and as just a pure form substance of use. Fentanyl for I think this group, probably everyone's familiar with it, but it's a highly potent short-acting opioid that is basically prescription grade, but also very, very cheap to kind of find without a prescription. So I have not encountered a lot of fentanyl adulterant in cannabis products, I will say. However, I encounter it all the time as either people just using fentanyl or unknowingly using it mixed in with stimulants or with other opioids. So I never thought, for example, the lieutenant before me was talking about Narcan, right, which is meant to reverse opioid overdoses. Our hospital system actually gives out Narcan to people using other opioids, but also using meth or cocaine, because so much of the meth and cocaine, unbeknownst to many of our patients, is actually adulterated with fentanyl. So my answer is I have not encountered a lot of adulteration in cannabis, but with the other substances I treat, absolutely. And fentanyl absolutely has led to this like newest wave of opioid overdoses, which we're trying to overcome.